I want to share with you one of the weirdest DMEK cases that we have done in a long time. A patient that we operated on just a couple of weeks ago here in our office. And Philip and I are going to walk you through the operation and show you, I think, the learning points and perhaps some of the mistakes that were made. So if you are doing a similar case in one of your patients in the future, you won't have to experience the same little traps. I'm Jack Parker. This is Philip Dockery. We're two of the cornea specialists here at Parker Cornea, and we're excited to get into this video with you today. So this is a super interesting patient that found us on his own, and he had had long-standing Fuchs dystrophy. He knew that, but he also had recently undergone cataract surgery with a goniotomy by a very talented local ophthalmologist. And even though the surgeon was really good and did a great job, in the aftermath of that operation, he had had bleeding. And specifically, he had had bleeding from the trabecular meshwork from the goniotomy, resulting not only in a hyphema, but blood pooling in the capsular bag behind the lens. And not just a little bit of blood, a humongous lake of blood occupying the space in the posterior capsule. And the operation had been 4 months ago, and he comes to see us. And the vision in this eye is doubly limited by this giant welling up of blood behind the lens and also decompensated Fuchs endothelial dystrophy. And when Philip and I saw this patient, it was not clear at all what to do. I mean, it seemed like both of these problems had to be addressed. But how? You know, in order to get the blood out from behind the lens, presumably you need the patient dilated. To do DMEK, you need the pupil constricted. In what order should things be done? Should they be done at the same time? Should they be done separate times? What should be done wasn't at all clear. And this video is what we decided to do. And specifically, the goal is to take the patient to surgery, wash the blood out from around or behind the lens, and then bring the pupil down and try to do a DMEK over the top of that. So that's the thought process going into the operation, and we'll walk you through the steps and show you kind of how that goes. All right, Phil.
Yeah, so we're starting out the case how we always do for every DMEK. We're doing a sub-tenons block for the patient's comfort and anesthesia. One thing that you do notice prior to the block is that you see a very small pupil with a black reflex because of that blood. After the block, the pupil dilates and becomes more, we can see the red reflex. And you see this very demarcated line of where the blood is located. And in the pre-op area, we were thinking, is this heme adhered to the lens? Is it adhered to the posterior capsule? Is it just a clot, or what's going on with it? You can also notice that the anterior chamber is very clear at this point. But as we make our wounds, that may change.
Yeah, it's amazing. You know, the blood seems very consolidated here. And when we were seeing this patient in the clinic trying to figure out what to do, you know, it really was, my thought process was this is a big lump of something, a clot stuck to the back of the lens, and it would have to be physically disengaged from the capsule or from the IOL. That's why we didn't do a YAG on the patient in the clinic, because we thought, well, if we open the posterior capsule to drain the blood with the YAG,
it's still going to be fixed to the lens.
And the blood doesn't go anywhere, and now we have to go get back behind the lens to wash it out, so then we're going to get into vitreous. So that's the reason why we discussed but didn't want to do a YAG, because we thought if we need to get behind the lens, we don't want to be tangled up in vitreous. And here, looking down at the eye, it doesn't look like the blood is just suffusing the capsule. It doesn't look like it's rolling around back there. It looks like it's basically fixed in place. So anyway, we're continuing on with the plan. We're making these paracenteses as we always do for DMEK, but they're also nice for use during a procedure in which you're trying to get around and underneath the lens. It's nice to have various vantage points. We're instilling this preservative-free lidocaine into the anterior chamber for anesthesia to supplement the block. And now we're getting some bleeding from the trabecular meshwork.
And so I was saying it started off clear, but now we're getting some bleeding. Keep in mind, the surgery with the goniotomy was 4 months ago.
And this
patient
wild?
is still developing a spontaneous bleeding whenever the pressure gets low during the surgery.
4 months ago, and they're still bleeding from the goniotomy. So we fill the anterior chamber with a cohesive viscoelastic, so we don't have to worry about leaving any of that behind during DMEK. And now this is a 30 gauge 1-inch needle with viscoelastic. And we're using that to try to tease up underneath the anterior capsular rim and to squirt small amounts of viscoelastic behind the optic to liberate partially the optic from the capsular bag. But mostly the way we're trying to free this lens up here is with blunt mechanical dissection. This is a cyclodialysis spatula, and we're using it to sweep around the edges of the lens and underneath the capsule. And this is controversial. Most people who say when you're doing a lens exchange, you should be using viscoelastic to protect and preserve the capsular bag. The problem with that is when you use viscoelastic here, the temptation, the tendency is to inject so much viscoelastic into the eye to try to separate the bag from the lens. You end up pressurizing the eye, and then you get iris prolapse, and then the pupil shrinks, and it becomes so much more difficult to see what you're doing. So in my personal controversial opinion, I think it is better to gently and gingerly free up the IOL from the capsular bag with direct physical touching rather than by injecting tube after tube of viscoelastic. And that's what we're doing here. And then once we have enough space and separation made using the cyclodialysis spatula from around the lens, the plan is to pop the lens up and see what's back there. And that's what we're doing here. I'm sort of elevating one edge of this IOL up, and then we're going to use a bimanual irrigating aspirating setup to try to remove whatever this is back from behind the lens. So here we go. We've got the irrigator in one hand and the aspirator in the other hand, and it turns out this big wad of something looks like it's liquid blood, even though it's been 4 months. But maybe we should have known that when we see this extra bleeding coming into the eye here from the trabecular meshwork now. But I was very surprised to see that was just a liquid aspiratable lake of blood in the eye.
Yeah, and it didn't even aspirate up like it was a clot or anything. It was just like it was straight up liquid that happened yesterday.
Yeah, exactly. So now, anyway, we're proceeding with the DMEK. Phil, what are the steps we're going through now?
Yeah, so now we just put myocol in the eye so that we can constrict the pupil and get a better anterior chamber. Then we put the AC maintainer with air to provide a little space to do our decimum rexus under air to help with the visualization. And here you can see we've already stripped, and now we're just gently pulling that decimum rexus out. And you can see, compared to when you do it under viscoelastic, the visualization of the decimase membrane as you're peeling it off is really much better. And then we're getting across, making sure you peel it all from the wounds, you're peeling parallel, and then you just pull it right out through the main wound.
Yeah, and that was really slick, it was really nice. But this eye has been bleeding continuously since we started the surgery from the trabecular meshwork. And in my opinion, that's one of the most ominous signs when doing DMEK is bleeding from the trabecular meshwork, because that is really where you get fibrin in the eye. It comes not from bleeding in general or bleeding from the iris, it comes from bleeding from the TM. And this has been an eye bleeding from the TM for 4 months, and that continues on into this case. So I think in the back of my mind, I'm very concerned about the presence of fibrin in the eye. So with that in mind, the goal is to inject this graft and to unfold it quickly. It's never good to rush through surgery. You want to be deliberate and thoughtful and methodical. But at the same time, there is some safety in being able to do things rapidly rather than feeling like it takes 10 minutes to get the graft in exactly the right position or what you want. If you can do things quickly, the chances of you running into a problem are much, much diminished. So
let's go through this thoughtful and methodical but efficient graft unfolding.
Great. So here we are injecting the graft into the anterior chamber.
So after it injects in, you can see the graft is slightly kinked so that you know that the anterior chamber may be just a little bit shallow.
Yeah, exactly right. And that's an important thing, by the way, guys. Pay attention to that. The graft is not this rigid vertical tube of cells. You'll notice there's this slight bend in it. And that slight bend comes because the iris diaphragm is bowed up because the chamber is shallow, okay? That's what that kink in the graft originates from. So because the graft is kinked like that, you know that the chamber is shallow. And therefore, unfolding this graft will depend on deepening the chamber. But before that can be accomplished, one thing has to be done first.
I'd get that air bubble out.
Let's get the air bubble out. That's always the first step of DMEK graft unfolding, is remove the air bubble. And of course, this is like all of our videos, completely unedited once the graft is in the anterior chamber. Okay, and sorry, we're skipping ahead a little bit too much. Okay, so we remove the air bubble, okay? And then what's the next step after removing the air bubble?
Removing the air bubble, you can kind of just look at the orientation, and the orientation looks like it's in some sort of single, maybe partial double roll, but it's a loose roll. So that's a good sign too. So hopefully it'll be easy to unfold. And but first, like we were saying, we need to deepen the chamber so that the graft isn't kinked.
Yeah, that's right. So we know the chamber is shallow because of the kinking of the graft when we inject it. And then we aspirate the bubble, and that's not going to make the chamber any deeper. So we know the chamber is shallow and needs to be deepened. And as we look down at the roll, it doesn't seem like it's tightly curled up on itself. It looks like it's kind of lazily flopped over. So we're optimistic that this is going to be an easy graft to unfold. But step one, deepen the chamber. We want to deepen the chamber to give us room for the graft to open up. And so the graft can sort of declare itself in what morphology, what pattern it is exhibiting. Here, like Philip was saying, it's not really obvious, the graft, how it's curled. It's maybe a single roll. It's not really obvious what morphology that is. And maybe that's because the chamber is shallow. So we're going to deepen the chamber and flush the graft and see what it does. That's the plan. So here we are, deepening the chamber, flushing the graft.
A little bit. And then now we've got this double roll. It's like kind of an asymmetric double roll. It's kind of like if you have kind of almost like this in the eye. So instead of the typical double roll where you see it, let's see, we can just use this. Typical double roll where you think of it like this. This is probably a little bit on its side.
Yeah.
And we can see this bottom flap, that little one. We might be able to just pull it open towards us by shallowing the chamber through the main wound, as you see.
Yeah, that's right. So we've deepened the chamber, and that's allowed the graft to sort of move a bit and assume a conformation that we can recognize, which is to say a double roll turned on its side. But to unfold the graft, we need the shallow chamber again. So as Phil was sort of intimating, we need to shallow the chamber now that we understand what's going on with the graft. There are many different ways you can shallow a chamber. I like to use the main wound, and the reason is it's most effective. You get the most bang for your buck when you're using the main wound. So that's what I like to do the most efficient thing. It's also important to keep in mind that when you shallow the chamber and you burp a wound, that draws fluid out of the eye, and it exerts an attractive force on the graft, okay? That's why people are afraid of using the main wound. They're worried about the graft coming flushing out of the eye. But as long as you're careful, that attractive force can be not a hindrance, it can be an asset. You can use it to move the tissue. So here what we're going to do is we're going to shallow the chamber by burping the main wound, and that pulls this edge of the graft over like that. See? Now one edge of the graft has been pulled over, and this is more clearly and obviously a double roll because that one edge has been attracted over. And now the way we open this loosely, lazily curled double roll is by taps on the center in between those two rolls, which works 100% of the time. That's what we're going to do here. And we're going to use that Dirazomer technique to help us with that because it's a little bit more efficient. And now just with a few little Dirazomer bumps, we have the graft fully unfolded.
And right side up.
And right side up. You can see that little orientation notch, and that's nasal. And that orientation notch is half of an arrowhead, and it points around clockwise. Okay, and that's how you can tell the graft is right side up. And now we're just lifting the graft up to the posterior surface using an air bubble through the main wound and pressurizing the eye. And that is the end of the operation. So, why do we share this video? Well, the first thing, the reason I thought that this would be a good case is because I've never done a case like this. I've never done a case where you have blood behind an IOL 4 months after a goniotomy, and you have to get the blood out, but you also have to be up on front of the IOL to do a DMEK. And so we did not know what to expect. So I thought this was a sort of an interesting combination operation. The second reason why I wanted to show this video is I thought it was a very nice, logical display of the thought process that goes behind graft unfolding. People talk about this DMEK dance where it's this, mystical, magical unfolding process, but it's this very predictable, straightforward series of moves that work every time. It's not, you don't have to be a super genius. You don't have to be some incredibly talented surgeon. You just kind of have to know what the tricks are. And here in this situation, the graft is injected into a shallow chamber. You have to deepen it. Then you can figure out what the pattern of the roll is. And once you've got the pattern, you know how to unfold it just because of taps here or there work every single time. So that's the second thing I thought was interesting. But the third thing was, now looking back at this case in the aftermath, and by the way, the patient has done great. It's been 3 weeks since the surgery. The graft is fully attached. He's not bleeding in the anterior chambers. There's no hyphema. Everything looks good. But still, I wonder if this was the right thing to do. Yeah. And I still don't know the answer to that question. But discussing this before we made the video, I think if I had to do this case over again, what I would do, rather than go back around the lens, dissect the lens from the capsular bag, use viscoelastic, and then aspirate the blood, I think what I would do is start the case by immediately putting a trocar into the eye or immediately accessing the pars plana and using the vitrector to vitrectomize the posterior capsule. Because that would have definitely worked in this case. It definitely would have removed the capsule and the liquid blood. And even if there had been some stuck-on clot instead of a pool of liquid which dissipated, probably you could have vitrectomized that clot. Mm-hmm. And even if not, even if you still have to go back around the lens and pull the lens up, the eye is vitrectomized. So you shouldn't have to worry about getting into vitreous. Yeah. So, this worked. What we did worked. And this was my idea. But the idea that I think it'd be better to use the vitrectomy first, that's Philip's idea. That's what Philip told me I should have done. I think he's right. I think that would have been the better way of doing it. And we thought about that to start the case, but in this eye that I thought maybe we have to be going around and getting behind the lens, do you really want to open the posterior capsule if you're going to be fishing around behind the lens? That scared me, but I think it would have been the right thing to do. I still think YAG before would have been the wrong move. I think that I would be too worried about yagging this and having not clearing and then not really knowing what to do. Yeah. So I think if I had to do this case over again, that's what I would do differently, is immediately start with the vitrector. Now, that said, the difference between that and this is, with that, where you immediately make a pars plana vitrectomy, you've got to be able to do DMEK in a vitrectomized eye. So I think the preferential way to do this operation would have been DMEK in a vitrectomized eye. So it's what we say on the video on the channel all the time. You have to be able to do DMEK in vitrectomized eyes because they're so common, and so much of the time the best way to do the surgery is to you yourself do a vitrectomy at the time of the operation. So that was the learning point for me during the surgery. Thank you guys so much for watching. Always nice to do presentations with you. If there's anything you want to know, want to watch, want to see, please let us know. If you want to be a fellow with Parker Cornea, please reach out and talk to us. We're always looking for good, smart people like Philip to come join us. Thanks so much.